Her position is healthcare and life science industry specialist at Google Cloud Latam. At Google Cloud, Priscila is instrumental in helping strategic customer and industry partners across Latin America define and execute the digital transformation vision with healthcare and life science. A distinguished healthcare leader, she's driven by a profound passion for revolution healthcare by leveraging technology to make care more accessible, efficient, and personalized. Her academic portfolio includes a Bachelor Science in Nursing, Advanced Studies Program in Health Administration from Hospital das Clínicas, and MBA in Hospital and Health System Management from Fundação Getúlio Vargas, and Advanced Studies in Entrepreneurship and Innovation at Babson College, United States. Please, Priscila.
It's a pleasure to be here today. It's a very important moment to discuss the actualization, the update of the Declaration of TP. So I brought some brief concepts and an overview about some 10 points. That's a recommendation, something that, in my view, would be awesome if you could review or consider these kind of points in your discussion in the review. So first things first, how do I switch? Is someone over there clicking? Yeah. Oh, thank you.
Makes it easier.
Yeah. So when we think about the care and the accessibility of healthcare data, we are living an amazing moment where data is pretty much organized and accessible for healthcare workers and the patients. Okay, we have some silos, some fragmentation, but the data is more available than ever. We are connected, we have this registered, and we are not only talking about structured data like forms and interviews that we have with the patients. We have all the imaging, we have voice recording, we have access to different kinds of data, and that's important to mention. When we are talking about healthcare data, we are talking about the data that we have on our electronic medical records, but we are also talking about the data we have on devices, either from the patient or from the healthcare professionals. As a nurse, I don't know from your side, but I had many pictures of my patients in my cell phone because some skin lesions, I couldn't bring this to the electronic medical record, so I had to start in my personal cell phone or even in my corporate cell phone. So when we are talking about data, let's open and give this big picture of what is clinical data, okay? So this is something that, better? Because it was echoing. Oh, please give me feedback on sound. Okay, better right now? Okay. So one thing is important is to consider this. What is healthcare data? Where is it and how we use? I'm pretty sure you are already discussing this stuff, but just to remember that we are not talking exclusively about things that are in the electronic medical records. Okay, these kind of things allow us to have a 36-degree view of the patient. We want to be holistic with the patient and understand their journey, their history, and not start all over again when the patient enters to the encounter. Okay, so it's a progress, but at the same time, we have some tensions about this, specifically when we talk about clinical research. Now we have a new way of doing research, which is real-world data approach. It's amazing. We don't need to select a group of patients, a cohort, and start to interact with them and see what happens. And sometimes when it's too risky, we need to stop the research, the intervention right now. We can work with real-world data from patients from the past 5, 10, 12, 50 years and see what actually happened when they interacted with some medicine, with some therapy, or if they did nothing, okay? So this is amazing for the evolution of research and for ethics. We are trying to connect even more and more data because we know the data is available, so we try to cross and enrich the database. That's what we actually say, oh, you have a data silo, let's bring a partnership in a multicentric study, in a multicentric research. We have 2, 3, 4 organizations that the same patient, we are not talking about different patients, we are talking about the same patients that has some part of information over there in the laboratory, over there in the hospital, over there in the insurance company. If we bring all this data connected and anonymized, of course, we have a more broad view of these patients. It's amazing. But at the same time, it's very complicated in the ethical aspect. Are we really transparent with the patient about this kind of linkage of data? Although it's important for medicine progress and research, and we know we are really responsible, we are doing this for the best, but it's clear, is it clear for the patient that the data I am sharing with my laboratory for research is probably going to be shared with many other research centers and cross it with other information that, in this case, 1 + 1 is not 2. We are multiplying things. When we have the data from this patient, from different organizations, we have a view that's bigger than the sum of the parts. We have deeper insights. As I said, that's awesome, but it's also tricky and risky, and I don't think, it's my personal opinion, that this kind of thing is really transparent for the patient. So we need to discuss the ethical governance about this kind of technology, this kind of approach, and the speed of the interoperability of data. So we are really connected. We are working with different platforms of real-world data. And even if it's not real-world data, we are doing studies like traditional cohorts, but we are linking data from the whole journey of the patient. This is something usually not pre-discussed with the customer. So, reflecting in the in the last text of the Declaration of Taipei, you have some strength that you already tackled the data set that's in a data lake or everything that's stored, okay, that is static, or as we call in the tech side, at rest. But we are not talking about utilizing over and over in new researches and connected with different data. The data that's gonna be shared, even though anonymized, can be de-identified depending on which kind of data we bring together. Let's use this example. That's the more obvious one. Genomics. If we cross some generic de-identified database with genomic database, it's almost impossible to not identify the patient. So that's pretty clear. But we can go further for less obvious situations. Depending on the kind of information that we piled up, it's so specific that in that street, that's only a person with these conditions that's identifiable as well. So for healthcare professionals taking care of the patient, it's amazing to have a broad overview of the patient, a more deep overview of this patient. But for the privacy of this patient, it's very complicated when we pile all this data from his or her journey. It comes even and even less de-identifiable, okay? So we need to consider these kind of things. But not talking only about the problem. is there any solution to tackle this issue? Well, actually, there is. There are some technological solutions and some what we call architecture, which is odd because let me explain. I'm a nurse and I came to a tech company. My role over there is not nurse. I'm an engineer and architect, which is not my. It's not what we think about an engineer building buildings or architecture designing blueprints of buildings. When we talk about engineers and architects in a tech company, it's the people that design the technical solutions for softwares and databases, okay? So I was even joking in the invitation that they were talking, that sounds great in Portuguese because they thought they were inviting uma engenheira do Google e uma enfermeira do Google. Foi almost there. But when we talk about and I don't want to be so deep in the technical side, but what we as architects in a tech company think about is how can we build solutions that protects key principles like privacy, security, and many other aspects, ethics, regulations, okay? So the industry, the tech industry is very advanced in building solutions that allows governance and control about not only static data that's stored in your database, but in these movements are how this data changes according to the context. Whenever I put it together with another data, this changes, the information I can get from there changes. So we create pieces that we call APIs that allows you to consider every situation. So I have this data and I'm protecting this in this storage. Whenever I interact with another data, my system will behave differently in order to prioritize the privacy and other criteria that we establish, okay? So there is solutions, but usually we are really, really too far. We are either discussing health and ethics or we are discussing technology. We don't used to be in the same room. So I invite all of you to understand this kind of aspects. You don't need a bachelor degree in engineering to understand all that, but there are many resources that are specifically designed for healthcare sector to protect the data, okay? I will show a little bit of them, but I just wanted to reassure that there is something and to like bring some literacy about that. Some awareness, not the literacy, some awareness, like a light at the end of the tunnel. So, for these APIs that I was mentioned, there is a problem of the anonymization that we already covered in the previous slide. So, I have data that's anonymized in one context, that's a database, but whenever I add more information, maybe it is no longer de-identifiable. So we have many solutions, that's not an exhaustive list, that works for every specific situation. So how do I work with a standard of data that's we use in healthcare, like FHIR, HL7, DICOM, LOINC, OMOP. We have many standards specifically designed for research or for healthcare data transfer, and we have solutions to manage all of these. We have solutions to constantly de-identify, even in images like pictures or upload of MRI, this kind of solution, without losing the metadata. So I'm not losing the information that this X-ray is about lung. It's written over there, right side, left side, but all the sensible information is raised. We have technology to keep updating this. We also have other technologies that I didn't put over here that allows us to interact with other kind of data. One I brought here, which is voice, because voice is a personal data. I can identify by a pattern that someone is speaking, not the other person. But we also have other kinds like genomic data, and we have some solutions like AI or foundational models to interact indirectly with these genomic data. So I will not bring the genomic data, will bring the information, the insight for the research. That's another way, that's another way to not risk privacy and anonymization. I could deal with this data, bringing what I need, which is information and insights, but not the direct information from the patient that is identifiable. I can, and I like to use this joke because people use this with me, I can Google the genomic sentence, and I can ask for a variant. I can ask for some information. I can Google the DNA. We have solutions in the market, specifically in Google, but in the market in general. We can Google the DNA. So I can find the information without reading every personal information on this sentence. That's amazing news. I don't know if everyone's aware that this kind of solution is available right now, okay? The other thing is the centralized databases. So we are already advanced in this topic because in the previous slide I already said that we assume that all the data is centralized, and the declaration of TPA, from my perspective, assumes that someone has a data lake, because you mentioned the data lake, but you do not consider the state of the data in the transfer. Sometimes the data is not only here. The data can be in many places at the same time. It's stored here, and I'm sharing with someone. Before it goes to the other center, to the research center, it is in the transfer. And the company who is responsible for the transfer, it's not covered by the declaration because it's not a data lake. It's another state of the data, okay? So we need to consider these kind as well. For healthcare, not research, for healthcare in the United States, we have the HIPAA, which I think you already heard about. So all the companies, even though not enrolled in the final activity, they are co-responsible for everything as well, for maintaining privacy and security of the data in every state. So HIPAA is a great benchmark to consider this. It's not designed for clinical research, but it's designed for healthcare. It's for data protection. So remember that the data, it's not only centralized. It's not over here and over there. It can be sometimes in the transfer. And I mentioned the algorithms and the indirect ways to interact with the data, but also I would like to add, to audit the data. It's another resource that you can use to keep up with the huge amount of data that we are storing, sharing, and analyzing right now, because it's too much. It's almost impossible for just a human to be able to monitor everything. So you can count on technology to be more transparent and have more governance. The third one is about authorization. So who can access what for what and when, and who allowed this? So the patient allowed share the data for one purpose. Is the patient, how does the patient can opt out in the case that it's not anonymized in the actual context, or in the future with another context? It's anonymized, but it's a different purpose. So how do we manage the data over time being used and used and used for different kind of research and purposes? So there are solutions for identity access management in order to trace and be transparent with the patient, not only for future use case, but if anyone, patient or organization, wants to audit and access and verify that everyone that access that data, access it for the right purpose, had permission to do so, it's important. So in the declaration that it's mentioned some attributions, some responsibilities, and I would like to highlight that we have the ability to make traceable all the use of data, all the logs, okay? So that's something that you could right now cover as well. And least, I would bring a fourth, but not less important topic, which is algorithmic bias and representation, which is, they are both a problem when we think about modern IT and all the discussion of AI, but it's also a long discussion for clinical research. We always have this trade-off. So we have some problem like some patients with rare conditions are not represented in databases. How can we assure that when I doing a research, I'm not ignoring them because of the principles that we have to not identify the person? Can we increase their representativeness by not only inviting others, but with other resources like key, I forgot the name, the key anonymity. So we have other resources to bring here. But on the other hand, we need to consider when I'm trying to interact indirectly with the databases and bring information for the identifiable case that I mentioned as an example. But how do I make AI to not purposely ignore it then? How do I make AI explainable and transparent in order to, okay, I understand without breaking the privacy of the patient, but I understand how you found this information, how do you brought this insight, and why we are moving forward in this direction, in that other direction. I'm not talking about outsourcing the research for the AI, but when you have AI in the game, specifically with unrepresented groups, we have to be considerable about this kind of algorithmic bias, okay? Because in research, we already have the K-anonymization resource in order to tackle this, but how we manage this with AI, it's important. There is a way, okay, but it's important to consider this in the use in the area of AI and agentic models, how we can provide actable care and develop solutions and research things that's useful for everyone, every single one. Okay, so in order to close my speech and invite the others here, I would like just to remember that today there are a lot of solutions available in the market. One thing is that we learned it from practice with the customers is that we don't need to build everything from scratch every single time. If we learn the lessons and we replicate what happened, what worked fine, and eliminate what didn't work, we can progress and have more safety, we can have more velocity. So what happens with cloud solutions like big companies is that we have a huge track record, and you don't need to start from scratch developing solutions to maintain the privacy and security and everything from scratch when we're talking about digital data of the patient. We can always evolve together, but please consider that sometimes, starting from the scratch, you're ignoring a lot of knowledge that are already developed and published, because we used to publish this a lot in Nature, Lancet, and many other journals, okay? And I invite the World Medical Association to provide a guidance. You could use this moment and this regulation to establish rules of engagement with the data and with the patient, in considering the timeline that's not statical. The data changes in context and everything we bring together. And remember that the data is a digital extension of the patient. We call it digital twin. It's not for nothing. There is a reason. The data is a digital twin of the person, so we need to consider it and provide the same ethical care. But it's complex. We are not, as healthcare professionals, really used to it. We don't know all the resources, so I invite you to be aware of not only the risks, but the solutions we already have available in the technology field. Thank you.
Very much, Priscila.
Eu vou começar perguntando, depois a gente abre para a plateia. Priscila, as ciências ômicas, genômica, proteômica, metabolômica, é um grande desafio para a anonimização dos dados, porque são dados extremamente difíceis de anonimizar. Esses dados, até hoje, nós não temos um método muito seguro para a anonimização desses dados. O que vocês do Google estão pensando em relação às ciências ômicas, a proteção dos dados dessas ciências?
Ótimo ponto, Jean. Dá para me ouvir direitinho aqui? Uma recomendação, o que a gente tem feito é trabalhar com modelos fundacionais e modelos que podem ser rodados localmente. Então, vou traduzir isso. A gente cria modelos especializados em saúde para cada uma das condições. Então, quando a gente pensa em modelos multimodais especializados em saúde, eles são adequados para a gente trabalhar com multi-omics, né? Eu consigo trabalhar diferentes tipos de dados num mesmo lugar, igual o ser humano trabalha. O ser humano, ele lê, ele assiste, interpreta, questiona. Então, a gente tem modelos especializados nisso, e que, em vez de eu treinar os modelos com os meus dados, a gente pega um modelo que foi treinado com a literatura médica e com curadoria médica, para ter a segurança de um determinado comportamento, tá? E que ele consiga agregar conhecimento. E a gente coloca esse modelo em cima de uma base de dados ou de diversas bases de dados, de forma que esse modelo ele interage com o dado de maneira anonimizada, e você extrai dali os insights e, obviamente, com o explainable do racional. Mas o pesquisador não tem acesso ao dado de cada um dos pacientes individualizados para fazer a análise. Isso é uma forma de garantir a privacidade e, ao mesmo tempo, trazer os insights e ter o avanço da pesquisa. E é importante ressaltar que essa estratégia não significa que você está treinando o modelo e exportando os seus dados. Não é isso. São modelos privados. Essa técnica que a gente chama de RAG. Então, ele vai responder com base na leitura daquele documento, mas ele não absorve aquele documento como parte do seu código e se muda ao longo do tempo. Então, a estratégia ela é meio do caminho ali e aí você tem a profundidade do seu caso de uso, mais a ferramenta especializada no seu campo de atuação.
Okay. Kloiber told me to ask the second speaker, and after we came back to the discussion. Okay? Well, it's an honor to present Roseli Nomura, coordinator of the Research Ethics Committee of Escola Paulista de Medicina, coordinator of the National Research Ethical Commission, member of the Research Ethics Committee of USP, professor at Paulista School of Medicine, Federal University of São Paulo, lawyer, specialist in medical law and administrative and constitutional law.
Thank you very much. I'd like to thank the organizing committee for the invitation, mainly World Medical Association and AMB, and in the name of Dr. Carlo Serrano, that invited me to be here. I would like to speak in Portuguese. Is okay? Ok. Então, bom dia a todos. Eu falo aqui nessa posição como uma coordenadora de um comitê de ética em pesquisa muito grande, como uma pessoa que fez parte de um comitê de ética em pesquisa também muito volumoso, que é o do Hospital das Clínicas, da Faculdade de Medicina da USP, e com mais de 10 anos de experiência na Comissão Nacional de Ética em Pesquisa, chamada CONEP, que encerrou suas atividades como Comissão de Ética Central, né, do Brasil, em dezembro do ano passado. E hoje, a partir do dia 25 de fevereiro, teve a primeira reunião da Instância Nacional de Ética em Pesquisa, que deve ser a nova comissão que substitui, que muda o nosso sistema no nosso país. A CONEP ela vai ter um novo papel, ela como uma comissão do Conselho Nacional de Saúde do Brasil, ela está se reformulando para ter um novo papel. Aos que não conhecem o sistema brasileiro, ele foi muito reformulado por conta de uma lei de 2024, e nós vamos comentar muito sobre a lei, porque ela impacta diretamente nas atividades dos comitês de ética no Brasil. Este é um mapa dos comitês de ética em pesquisa no Brasil. São mais de 900 comitês distribuídos em todas as regiões do país, concentrando-se muito no estado de São Paulo e na região sudeste, mas em todos os rincões, em todas as localidades extremas, o Brasil possui comitês de ética em pesquisa. Muitos vinculados a universidades, ou a grandes hospitais, ou a instituições de ensino, que acabam avaliando os diferentes protocolos de pesquisa que são propostos neste país. E é claro que nos últimos 30 anos, sob a organização da CONEP, esses comitês eles possuem todo um regramento para a sua atuação, toda uma construção ética para a análise de protocolos de pesquisa, inclusive a análise de protocolos de biobancos e bancos de dados. E os princípios éticos, os fundamentos da ética em pesquisa foram muito bem estabelecidos na Resolução 466 do Conselho Nacional de Saúde, cuja essa imagem ela representa os principais bases da ética em pesquisa, mas com a Lei 14874 de 2024, esses fundamentos foram reafirmados em forma de uma lei federal. E, com isso, ganha-se uma força muito grande para a regulação da ética em pesquisa no país. Quando comparamos as duas bases, né, dos fundamentos éticos, elas são muito semelhantes, muito próprias do que se defende a ética em pesquisa. O respeito aos direitos, a dignidade, a segurança, o bem-estar dos participantes,
the well-being of the participants, of the patients, the well-being, the benefit, the favorable risk benefits, scientific support with protocol, and that is approved by a committee with qualified researchers, and that guarantee the voluntary participation of the patients. The privacy is respected, and also the confidentiality of all the information supplied by those participants. Yes, it's necessary to have a necessary care during any intervention, ensuring technical quality and scientific validity, not only for the data, but also for biological material that might be stored, and of course complying with good clinical practice. Many of the Brazilian normatives are aligned to international norms, both in the Health Seeking Declaration and Type A Declaration. And the Type A Declaration, which is the one that we are discussing today, and the role of the Ethics Committee within this universe of which is the care of biobanks and databases. Type A Declaration has been considering what is a data bank and a biobank in the health field, and it considers all concerns regarding dignity, autonomy, privacy, discrimination, and this is all aligned to Brazilian law when we talk about research ethics. But what is the challenge? The challenge is data processing of this massive quantity of data. Information, added data for the samples, and also data processing, which is regulated by data protection law in Brazil. And then we have different types of data. And I'll mention a word that we use a lot, the sharing. We've been talking in different ways today how to deal with the data usage in an ethical way, and also the use of biosamples in an ethical way. Through CONEP, the Ethical Council has used the Regulation 738 regarding the use of database in the context of research. You know that data usage, the discussion in ethics committee is very general. All ethics committee in this country have the challenge of discussing this when any researcher decides to use great databases for research when they're not data banks for research. But for us, the consent is the base for research, and all committees work based on this principle. And we've mentioned and heard this, how necessary is the balance between advancement in science and the autonomy of the patient. This balance needs to be reasonable, so that the database, as precious as the one that has been presented, for example, the COVID database or any other database, be accessed and studied and generating the necessary knowledge that it can generate. The general principle of our resolution says that the protection of a database in the research context aims to preserve human dignity, the fundamental rights of research participants, informational self-determination, freedom, privacy, honor, and image. Again, we are aligned with the national and international declarations. But what do ethics committees do? They make decisions collectively, especially since the researcher brings us demands, proposals, sometimes good, sometimes not so much, and they need to be improved. But I would like to mention that the decisions are made collectively in all different committees and all committees in our country, because this is a framework that has been created in Brazil by the CONEP systems, which is a system between all the ethics committees. And what brings this system together is Plataforma Brasil. Plataforma Brasil is a national platform which is created by and maintained by DataSUS, which is the National Health Services Data Network. And the system is kind of overloaded. This afternoon, the vice coordinator of the National Health will be coordinating one of the tables this afternoon. He can confirm that they are having a lot of advances in the improvement of this system. But in any case, we have a system that has existed for over 10 years, 15 years. Plataforma Brasil started in 2010, has been in function in Brazil, where all researchers are registered in the system, and the ethics system is done through this platform. And researchers in Brazil know it very well. I mention this because in the last icon below, we have an icon, approved biobanks. So what are the approved biobanks in this country? They are available there. And with a single click, you can see we have 101 approved biobanks in Brazil. 101. These biobanks are not all registered in the Plataforma Brasil, because they need to be validated regarding documentation. They began to work outside of the platform. They were being validated, but in any case, half of the biobanks are regularly registered in the Plataforma Brasil, and half aren't. But there you find all the biobank list. Each biobank has the process with the health ministry, with registration, the constitution, the protocols and developments, their characteristics, all the commitments that the institution presented to CONEP and had the approval from CONEP. With this law, the biobank issues, they were suspended. They will be reconsidered now with the beginning with the national instance in national health ethics. And we are going to go through a regulatory process, but there are biobanks work in this country. What is being discussed all this morning regarding consent and the use of data and data from biobanks and
database for preclinical research, what I have to say is that the approved biobanks has a consent form that has been well created. They've been approved by CONEP, and they present a certain certifications and objectives. And if a participant wants or not to be contacted at each beginning of a new research in which your bio sample is going to be used, if they want that a relative be contacted whenever a research begins, or if they waiver that contact. So everything is being well organized in Brazil. It works like this, and after death of this patient that has the sample in the biobank, if they wish that a relative be consulted, the biobank has this ethical commitment with any participant.
What is different in the database of the research or health assistance? It's different from the big biobanks or even from an electronic records that we have in different institutions in our country. And this law here that is known by the research law has in its Article 18 a very clear way of showing it that the participation research is conditioned upon the express authorization of the participant or their legal guardian by signing the informed consent form. So see that we as researchers and ethical committee have this commitment, which is legal, to demand from the researchers this informed consent form. This research law was debated before being approved by the National Congress. And here in our Congress, they discussed it, but it has many good things. But there are things that are not so good. One of them that is linked to it, so if you wanted to use it freely, all the data for not this purpose, is this Article 18. It's aligned to the Declaration of Taipei that really values ethics to it. And then will all the clinical data before that, are we with our hands tied? The laws are translated, interpreted, and all the committees need to have guidances, unique thoughts, so then we don't take different decisions in the country. And we hope that this installation of this research committee brings us a perspective of it. This resolution is before the law, and then we have this way of using it through this anonymity, and through this law we still don't have the usage of the data, which is different from a collected data that is for research in a big data bank, and the participant has already signed a document, has already provided all the consent, all the specimen, and then it's different from what we have here. And what is the role of those ethics committees? So besides working with this challenge of protecting the participants' right without going beyond the development of science, so we have this document, as you see here, informed consent form, that is a tool that gives the rights to this participant. It's not only the role of it, it's the whole process, as everything is explained. So we have different features of it, but mainly the committees work with the main issues of it, It's not a proper language. Those are insufficient information, or even the lack of rights that are in the resolution as well as in the law of it that I have shown. So even in this law, one of the clear things in this article are the requirements of it. So today we have legal devices that support all the ethics committees to demand from our society that this document should be done properly with an accessible language, dated and signed. It's not an only document. It should be updated, everything that there are changes in the protocol that doesn't waive any kind of rights. And then it should bring complete information. It also allows the research to be done in an emergency situation, as we also have this in the declaration of Type A, when the participant can't consent that. It's an article that we discuss a lot. There is an institution in the Supreme Court questioning about it. Because because when the participant has an emergency situation, he doesn't have any kind of caveats that if there is a legal representative, you can have this consent. But that's how it is in the law. So including in our research approved by the ethics and the research committee, so they have this accountability. But the law demands that the participant should be consented as soon as it's possible. And I know that the right to withdraw consent and the other devices, actually other things, which is the access to the result of the research, because the participant should access the outcomes of it. And it's not always clear within the protocol as the researcher will do, and not even the consent term, but it's one of the rights that we are working on to do it. Okay, so the ethics committees will always be attentive to those risks and benefits for the participants, and if they are presented in this consent term form, if they are aware of them, and then in an autonomous way, they will decide to be part of it. So just to wrap up here, we have just some final notes that are aligned to what we do in those committees. We have been working on things that all the biological materials, all the collections are based on consent, on a free consent. And if the biological material are collected and stored in a health database or biobank for multiple uses, consent is only valid if the individual is informed about it. So it's not only a consent for clinical treatment. The consent that we sign when the patient is hospitalized, it's not the consent for research. And it's aligned to what the LGPD reaffirms, restates in their documents. So the purpose of it. And of course that all the professionals must be aligned with all the protocols and all the ethical things that guide those researches. Thank you.
There's already a first question. Yeah, well, good, good. Then we start with that. Please go ahead.
Agradeço a oportunidade.
I thank you for the opportunity. My name is Laura. I am a professor of the school of, I'm a professor at the medical school, and I will take advantage of this time to ask two questions, one for Professor Roseli and one for Patricia. Professor Roseli, do you think that it's feasible to build electronic records for the assistants? And then this way they will foresee the possibility of research with a clinical, like real world clinical data. So I'm not speaking of shortcut, but I'm speaking of this light of legislation. So for Patricia, I have a question. This is something that I think to myself. So the advances that we have in tech companies, because I use technology a lot, I like it a lot. So those safeguards for privacy, but sometimes I have an idea that in the end of everything, there will be a summit that when it's convenient because of a democratic government, or not even so, or not like not so democratic, will find a subject, an individual for any kind of action. Sometimes that cannot be good. Maybe those instruments can be better improved to ensure this place, because that's the feeling that I have. There is a level of data access that can solve all those techniques that somehow try to anonymize the individual and the data. Thank you. Thank you for the question. I understand that the electronic record is a reality in our country. So we have different ways of collecting data, and sometimes they are necessary for the research, but remember that you have a clear goal for research. And today we do have all the records because they are records for the research, the Brazilian Association of something, so we have all the disease, it's well structured in the whole country with clear goals and with a deadline. We don't have a unique thing, like we don't have a unique rule for that. I really hope that we can have that, to use technology for that. I will give an example, which is the discussion related to genome banks. We have to store. It's not we have to use them in the genome process in Brazil is being discussed.
On my list here is gentleman, the gentleman in blue shirt, the lady in the blue dress, and the gentleman in the gray suit. So those are the ones I have. You can, yeah, you will be second.
Vou tentar ser objetiva para dar tempo para as outras.
I'll try to be very objective, but related to your question, I will start saying that there is a distinction between the public tools that are for the general consumers and the ones that are corporate, the private ones. So when you put your data using a public tool, so the exchange that you have to be free is the data sharing. So that's why it's important to have governance in the health institutions by using private tools. In Google Cloud, to give you an example, they are not all the same. In Google Cloud, all the data belong to the company that has hired it. We don't have any access. We don't train any model. There is a security strategy, and nobody can access that. And it's in case there is any kind of invasion, even though we have lots of mechanisms to prevent that, it's almost a puzzle. So there are protection mechanisms. So the difference here from the private and public ones. It's important to pay attention to those points, to understand what I wanted to prevent, and then find a partner that will address those matters and ensure that my data will be safe, because I'm co-responsible for the patient's data. There are many tools for that, but that's the main one, to make sure that there is no company that will train.
To be very precise and as short as possible for both those who are making statements, asking questions, as for giving answers. You are the next one in the gray suit.
I believe it's me, no?
No, he is first and then you. You're second.
I'm first. Thank you so much. I'll speak in English if it's better. My name is Michael Tonini. I'm Deputy Coordinator of the National Research Ethics Authority, just created, and we are taking over from CONEP. My question is to Dr. Roseli, and I would like to know her opinion on the Brazilian data protection law, because it allows, Brazilian law allows for the use of data stored in databases that were not collected for research purposes, provided it's anonymized. And in your opinion, does that conflict with the Brazilian research law? And how could we circumvent this or harmonize this for infra-legal regulations? Thank you.
Would you like to answer immediately?
Yes, it's easy.
This general protection law is mentioned in the law of research, the one that the 1487 says that this LGPD will be applied in a way that first the research law is valid, and secondly the LGPD. So they are not in the same level. So we need to have this interpretation, because at what extent should we apply LGPD or not? And I see situations that will guide us through this situation. And then we have this, if it's anonymous, we can share some data, but in other situations we will not be able to. Actually, if we go through this medical chart, it cannot be released without this consent. But when we have this epidemiological situation, it's not, then it doesn't make sense to do a research with gross data. It's a challenge. Thank you for the question.
Bernardo Savassi from the Brazilian Society of Family Medicine. To Priscila, I know that maybe you have already answered to this question, but I have to do it again. They say that about the big data, that Google could predict the COVID pandemics by the number of searches in about flu symptoms. Do you believe that Google, with this big data, will be able
to predict the next pandemics based on the big data of regular people?
That's a billion-dollar question. So, yeah, because one thing we learned about this discussion, because we had the discussion internally, is that we need to remember that correlation is not causation. So, sometimes it could be a prediction, but sometimes could be a noise. So, being totally fair, I don't know because of this dilemma of correlation and causation.
Yeah. Yes, the lady.
To Priscila also, pretty interesting the concept of digital twin and how to use that further in research. Are you thinking about the ethical gap that will be created on how to get informed consent in a fair way, not just a signature or a click on an app that I do without thinking what I am signing on when I do wearables or research or data collection from myself moving forward, because it will remove barriers to research, but it also will pose a conundrum there on the ethical collection of an informed consent.
Yeah, so that's tricky as well, because although digital twins and real-world data, it's amazing to minimize risks, ethical risks in conducting interventions in research, it has its own problems. So we need to address, and that's why I said I count on you, group, in the update of the declaration to consider this scenario, because it wasn't directly covered in the previous one, and it's totally fair. We have some guide principles over there, but we need to analyze this situation. And Professor Roseli brought something in the beginning of her presentation, that's the challenge of data processing operations. So it's not only the digital twin at the end, but everything in between. So it's a big challenge. I don't know if a session dedicated exclusively to this topic, because it's pretty exhaustive. I don't know if only 30 minutes will be enough. So one thing, it's deep dive, and I don't know if you have the time to dedicate more research and find alternatives to guarantee the progress of research, at the same time, the privacy of the patient.
Thank you. Gentleman in the gray suit, please. No?
Sure?
No. It's not your turn. Sorry.
Sorry. Bom dia a todos.
Good morning, everyone. First of all, I'd like to congratulate the panelists for the wonderful presentation. And I'm director of I was charmed by the presentation. I'm part of the committee of ethics. First of all, I'd like to highlight, and I try to be objective. In Brazil, for a long time, we have defended the right of research, and the research needs to be defended. The subject of the research needs to be defended, and this created a barrier and caused difficulties for the research right from the start. And we have seen advancements with the Taipei Declaration, among others, such as how we've been correct in all of our opinion. But it's very good to have a representative of CFM here, and I was talking to him about this. We found ourselves in regular research that have a lot of demands upon them. And in Brazil, with the supplementary medicines, they use the patient data with different ends. And that I believe that we need to have a certain attitude. I agree with Dr. Giancarlo and CFM, so that we can have a defense for this, because if you submit yourself to a thoracic surgery, you have to send the sensitive data of the patient. And if the result is positive, if someone is HIV positive, everyone knows that the patient is HIV positive. And I would like to question Dr. Roseli regarding your point of view of this uncertainty of the data submission. Thank you for your question. The data used in the health system for health assistance They need to be protected to the as much as possible. They are patient data, and the National Council of Medicine, the Federal Federation of Medicine, has defined this, and it has been defined that the patient data needs to be protected, the medical chart needs to be protected, so it can only be used for health assistance intent. This is an ethical discussion because we know there are researchers at times that are more inexperienced, that want access. Also, the publication of information for supplementary health, they need to be protected. It's not just access, it's security. Security in the transmission of the information. And when you analyze projects and biobanks, the security evaluation is one of the criteria. It's part of our resolutions. And I see that we need indeed to protect the information, and we cannot confuse assistance with research. This is our biggest issue in our country, because there is confusion and interest conflict. The same person that is the doctor is the researcher. That could be a conflict of interest.
Questions here. Just a second. It's not you. It's first Professor sorry, Professor Jorge, then the gentleman in the dark suit, and then the gentleman on that side of the dark suit, and then everybody else, if you wish.
My question is to Roseli also. Here, Roseli.
Thank you.
I was also always thinking, from who the participant of research needs to be protected. I think that in the first place is from the researcher. In terms of privacy and confidentiality, all others' interests could be raised. But I will focus on the interest of the researcher, which is not always very much coincide with the interests of the patients when we have patients as participants of research. And I was, you have said that the decision of ethical committees collectively made. You belong to two big ethical committees that analyzes a huge amount of research project. I doubt that it's possible for the collectivity of the research committee to analyze each project. So there will be a rapporteur. And usually, the rapporteur is from the same institution of the researcher, and mostly from the same department. Is someone who sits besides the researcher that is proposing the project. So I think there is a potential conflict of interest in analyzing this kind of thing. I'm not saying that the rapporteur is someone that will act with no honesty in analyzing, but there is a kind of bias when you are evaluating something that belongs to a friend of you, not just a colleague. How you think that this is something that has an impact in the terms of the protection of the research?
Obrigada pela pergunta, professor.
Thank you for your questions. I'm part of a very big part of our ethics committee of the University of Medicine in São Paulo. I think it's the largest one, I'm not sure, in the clinical, Hospital das Clínicas in São Paulo, Clinical Hospital in São Paulo. But there are some as big, but that's not the rule. Most committees don't have such a big volume as maybe some of the top committees in the country. They have a massive volume in which the membership is so big. And usually you work in chambers with different smaller groups analyzing the different protocols. And yes, at times not all can be as detailed as possible. But when we work with a high volume of research, the issues repeat themselves. because the researches are all similar. They kind of make the same kind of mistakes and they have the same habits locally. So at times the decisions are homogeneous within a collegiate. But I do agree with you, there are conflicts of interest. They happen, they have to be handled, they need to be brought into light so that everyone in that committee understands the conflicts of interest. And a member that might have a conflict of interest needs to present themselves and step back from a specific research. That's the base of the system and how we work. And as a member of CONEP, I have given many trainings, discussed a lot. I know the challenges in a country like ours, which has more than 900 ethics committed. There are a lot of people, more than 18,000 people working with the same guidelines. So at times they are too strict, I think. Many of you know that. Many, they let things go, because the committees also make mistakes. But as a rule, our balance is more positive for the protection of the participants of research.
Yes.
Okay, thank you. I'll do it in Portuguese so I can talk about more details, okay?
I'm Bernardino Santi, Director of the Ethics Commission and Professional Defense of Brazilian Society of Sport. I'm a trauma surgeon in my private practice, but I was and I'm still represent a number of organizations who doping for doping control, anti-doping. I'm kind of a fish out of the water right now, but when we collect be it blood, urine, first of all, the athlete has to subject themselves to the collection of the samples. Then the material is sent to a lab. Of course, it's not identified. The identification of that sample stays with an authority and the results management. They are the only ones that know the results. And this athlete, and this is a care that WADA is the organization that controls the ethics in the world for the anti-doping agents in the world. And there is a little sentence that we put in the form that clearly states this sample can be cleared for scientific study, yes or no. And the athlete says yes or no. So they have a direct answer regarding that. Should this athlete having adverse result, the positive result, they will be judged, and if condemned, this result will be made public. What does the Type A says regarding this? I don't know if this is considered, and I would like to know the opinion of the doctors of this situation, because it's a completely different situation, but it is a medical situation. And we'll have to consider this because we in the future, and we already have some legal issues because of the athletes that are being punished. And the second challenge will be the gender issue in sports. And we are creating policies to deal with that, because the future is changing. So I'd like to present this challenge to the doctor and to all of us in name of the Brazilian Sport Medicine Society. Thank you.
Of your consent procedure. According to the declaration of Taipei, this consent procedure would certainly not be enough. If you just ask, can we use it for scientific purpose, that is not a really valid consent that is being given, yes or no. Because what you have to describe is how the data is being worked with, what can be done with that, and then how it is being protected, and how it is also being protected against being abused. And you need secondary mechanisms for that. So it is this consent. I don't call it informed consent. I don't call it broad consent. It is a consent plus a governance mechanism which must be behind that. That would be necessary to do that. But it is an interesting question because it is at the border of, at the realm of between medicine and commerce. And this is something which I find is a quite interesting question, quite interesting situation, and how far now questions of medical ethics dive into this situation of other uses which are not strictly medical research necessarily in that.
And even legal problems?
Yes, of course. Yes, they come on top of that. Any other answer to that question?
No, from the ethical perspective, no. The only thing is that if the case got released because it's public, you're gonna think about how to, not for research, but you anonymize it in the first hand. But now it's identifiable.
It's public,
how can you take this person out of the database because it's public information? You can compromise anything.
Yeah, but I guess that is something that you also in your direct contractual relationship with the athlete will clarify before and upfront. Please.
Bom dia a todos.
Good morning, all. My name is Rony de Cavallo Fernandes. I represent the Brazilian Society of Urology. I would like to thank Gelson and the participation and organization the MBA APN. In urology, the Type A declaration foresees the use and manipulation of gametes, embryos, within the declaration, because we have in our subspecialization fertilization. So I'd like to know if this is considered in the biobanks, gametes and embryos.
Question, but yes, it is. Thinks the declaration of Type A tries to take a transgenerational approach. So the question of effect of what you do by using data or specimen may not only affect one generation, it may affect your family as such, and it may affect the subsequent generations as well, and sometimes also the earlier generations maybe. So yes, it is something. It does not replace other policy which the World Medical Association has on reproductive medicine, for instance. Those have to be considered separately with that. Any further question? If not, I take the opportunity the last 2 minutes to confuse you with my questions, or at least one. You had some nice headlines there. One is, a data point is a digital extension of the patient. It deserves the same ethical care. This nearly has a transhumanist approach to that. Yeah, okay. That is fine. But my question comes to another sentence you phrased. Language must evolve from static storage. No, sorry, the other one. Ethical governance must move at a speed of the technological interoperability. This is a challenge. How is the industry helping us with that?
That's a challenge. And when we think about the industry, we are developing solutions to address something that we already have written. So HIPAA, Declaration of Type A, everything that's already there. But we are also pushing for new resolutions for the risks arise in our daily activity. So when we see a risk, when we see something that, wow, that's new and it's complicated, the society should be aware of it, usually we push and propose new approaches. Even though it's not regulated, we assume that it's the best practice. We have some principles that guide us. So it doesn't matter if it's mandatory or not, that's a principle and we should follow it. So this commitment and also the development of this solution, actually, it's not only about the behavior, but developing solution that can help with these issues that we see every day.
Thank you very much. We have an ongoing dialogue with the pharmaceutical industry about those matters. I think it is now time also to think about an ongoing dialogue with the IT industry about those matters. because those are challenges which I think the medical profession and the healthcare professions alone would be left alone and would not be able to cope with. Another question I have to you, Professor Nomura. We have spoken about research and this huge data wealth which you have in this huge country. But many questions which come up to the healthcare systems are really not research questions. They are questions of quality assurance, quality control. They are questions of structuring the healthcare system, of administrating it. And I know all of our healthcare systems have huge challenges. We have a growing demand in healthcare. We have steadily rising costs. We have a decrease in the health professions community by age and just a shortage of number there. So there must be a high number of questions coming from the administrative side which are not research, at least not in a classical term. Does your institution deal with those questions as well? Are you also looking into those questions, or is this a separate body, or is nobody looking for them?
No, they are looking for them. Vou responder em português.
I'm going to answer in Portuguese because I think it's better. The issues regarding research, we only look at research issues for ethics committees for research, but there is a lot of information in health, and Brazil has a whole information system for health that is massive and is used in an administrative point of view for public and private organizations, and that is the administrative side for healthcare that is not discussed. No one discussed how important is the need for the use of that information for public policies and from private policies for administrative, for a number of different companies. This doesn't come to us, but eventually they cross, because sometimes the mortality information, we have a massive system for mortality and birth control. They are looked up for research purposes. In those situations, we have declarations, the legal parameters of how they can be used without consent, because the raw data is supplied from the digitalized health system, the national registry.